this high signal without fat saturation also. This is fat saturation, this is without fat saturation. Tells you that this is not fat, otherwise it would have saturated. So what do you think it is?
So these lesions have got inherently high T1 signal, and they're multiple. In the context of an older patient with other suspicious features, I'm worried about disseminated malignancy with inherently high T1 signals, such as metastatic melanoma.
Melanoma, okay. Did you pick up something here in the spine?
Yeah, and we told the patient has back pain, and there's a vertebral lesion with similar characteristics.
Yes. So the point is that this was just to go through this differential, which is in your book 8.223, T1 hyperintense liver lesions. And, fat, hemorrhage, cirrhotic nodules, melanoma, these ones you have to remember, particularly melanoma, and particularly anything which has got fat. So T1 hyperintense. On a DWI, look here, this is B1200. And what do you think? Benign or malignant?
So the lesions demonstrate high signal on the high B value DWI images, which is consistent with restriction of diffusion. There's also many more lesions apparent on this more sensitive sequence, and I think this makes me more worried that this is a disseminated malignancy.
Excellent. So this was melanoma metastasis, and if you see here, this T1 is very interesting. On a T1 weighted sequence, you can see this high signal here. And usually high signal on a T1 weighted sequence is the good news in marrow. But this is an exception. Here, usually melanoma metastasis will, they can be what we call a melanocytic melanoma metastasis also. But some of them, the melanin part is so much that it can, even in bone, it can show you. This is a very rare finding actually. Usually you will see low signal on T1. And on a stir sequence, there is a bit of chemical shift here. And so this was metastasis. And on the scout also, you can see high signal on T1. And within the liver, you can see within the spine, you can see this high signal. This is a fat saturated scout. So this is melanoma metastasis. This is your last case, candidate 1. This is not a metastasis, right? This was a cyst. So on this slice which I have given you, is there any other lesion? We are worried about metastasis.
So it's difficult to say on a single axial CT. I wonder if there's something very ill-defined and mildly hypoattenuating in the left lobe.
What will you do for this?
So I would probably do an MRI or an ultrasound.
For that, you are sitting in the exam. This is a viva question. Something which you can do here and then.
So something I can do right here to change how I feel about this is windowing the differently.
Excellent. So the point here is that there is a window, we call it, and this scenario has been asked by the examiners. Liver window, which increases our sensitivity. And in liver window, this is the liver window in our packs. It might be slightly different in yours. So now with this, what do you think, candidate 1?
So I'm convinced there is something real there. It's got quite poorly defined margins, and it does look quite concerning. But I'd still potentially.
Here you are. So this is the MR. What do you think it is?
Okay, so this lesion remains very poorly defined. There's some hazy, mild increased T2 signal intensity, and it has arterial enhancement with washout relative to parenchyma. So I think it has definitively malignant features.
Yeah, so it shows classical washout. Okay, so I think this is a break time. We will 5-minute break, and then we will start with candidate 3. So thank you very much, candidate one. I'm going to mute myself for 5 minutes. Are you with us?
Yeah.
Okay, candidate three. Let me clear all drawings. So if you see here on ultrasound, there was a mass in this case.
Mhm.
This mass on T2 weighted sequence and on this DWI sequence, how will you describe it? Over to you.
So it's a selected slices of MRI liver, T2 slightly heavy liver T2, and then T1 non-contrast, and then diffusion weighted images, which is demonstrating a slight hyper intensity, intralesional slight hyper intensity in the right lobe of liver where the lesion is, which is, I think, losing its intensity slightly on heavily weighted T2, while on DWI there's diffusion restriction. On T1, the signal is hypointense.
Okay, so with this bright DWI, high DWI, benign malignant.
Malignant.
Okay, so on arterial phase, the patient moved a lot, and this usually happens on arterial.
Sure.
Having said that, you can see a bit of enhancement.
Yeah.
Then venous, then this, then this, then this. Can you describe it?
So so on venous phase, so on venous phase, there is some peripheral nodular enhancement, which at 3 minutes, 5 minutes, and 10 minutes, there is gradual enhancement, centripetal enhancement pattern of the lesion.
So,
which is peripheral nodular.
Okay, so what is your conclusion?
I'm thinking of now hemangioma, because hemangioma can be diffusion restricted, and with this contrast enhancement pattern, hemangioma comes into my top differential here.
Okay, but the point is that if you just see this periphery of the lesion, there is a central scar.
Yeah.
If you see the peripheral of the lesion, it has shown washout. Correct or not?
Correct. Yeah. Correct.
And why you are confused is, and this is the teaching point here, and this is what I am going to teach you now. Why you are confused is because the central part has now enhanced, right? Agree? This is what has confused you.
Yeah.
So this looked malignant, but because of this centripetal within inverted commas enhancement, you are now confused. And the point here is that this is a fibrolamellar HCC. Now, what is happening? That the central part is fibrosis. So what happens is there are two differential diagnoses which we have to cover here. One is liver lesions with a central scar, focal nodular hyperplasia, fibrolamellar HCC. There are many things which can have a scar. Even metastasis can have a central scar. And there is another differential, which is what we have to cover here. Liver lesions with gradual delayed enhancement. Mass-forming cholangiocarcinoma, hemangioma, you can add, this scar also there. What happens is, first of all, mass-forming cholangiocarcinoma, what we call intrahepatic cholangiocarcinoma, has got various patterns. And the pattern which is for 2B is this one, mass-forming. It will be just like a mass. Now, if you know your pathology, you can make your radiology here once again. Basically, people do confuse it, hemangioma versus intrahepatic cholangiocarcinoma or any tumor which has got a fibrous scar, basically what happens in a intrahepatic cholangiocarcinoma or a mass forming cholangiocarcinoma, the active component of the lesion is peripheral, and centrally there is a lot of fibrosis. This is histologically speaking. This is the behavior of it's a Skirris type of a tumor. And similarly, there are some metastases which have got similar histology. So there will be a bit of fibrosis centrally. Now, if you look carefully, if I come out of my pointer option, I am just trying to change it into. Now, if you look carefully, there is a bit of enhancement in this lesion in the periphery. This is an arterial phase. Actually, enhancement. Now, just keep comparing it, and you will see that it is enhancing. Gradually, there is what we call centripetal extension. No, this is not that hemangioma type of enhancement. This is fibrosis. In hemangioma, one take-home point will be that the periphery of the lesion shows nodular enhancement. Number two, it will not be continuous enhancement. There will be some gaps there. Another point to remember is that in hemangioma, the signal intensity of the enhancement is equal to blood pool. We use the word blood pool. What does it mean? It means that it is equal to, let's say, the vessels in the, the hepatic vessels or the portal vein, etc. That will be the signal. So otherwise, and you will confuse it. So scar or fibrosis will enhance with delay. And that was the learning point in this case. Look here, this is an intrahepatic cholangiocarcinoma, which is quite peripheral. It is here, and there is a dip in the capsule of the liver. This is the dip. This is what we call retraction of the capsule. Now, if you see inside the lesion, this is arterial, there is peripheral enhancement, and then it shows, enhancement on the delayed phase. And similar behavior can be shown with what we call Skirris metastasis, particularly breast metastasis. Please remember that there is an appearance in liver imaging, we call it pseudo-cirrhotic appearance. And I've seen cases of breast metastasis which are so Skirris that they will cause outline of the liver will be totally, nodular. So how do you differentiate this? I repeat, with the hemangioma. First of all, on a T2 weighted sequence, a hemangioma will be more brighter. Number two, the enhancement will be nodular. It will not be continuous on early arterial phase. Number three, the enhancement will be equal to the blood pool. What does it mean? So if you just concentrate here, this is the portal vein or the hepatic vein, and you see inside the lesion and look at the enhancement inside the lesion, it is not equal to that. It is less than that. And look here, it is not equal to this. So these are the discriminators between intrahepatic cholangiocarcinoma versus hemangioma. This one I'll skip it. Okay. One case which has come in the exam many a times, I've got a very good MR also for this, a similar case, which I might show you if I've got time in the end. The problem is that many of these cases are on DICOM sequences, and usually when I do teaching, I show it like that. On Zoom, it becomes a bit cumbersome to, screen sharing, etc. Everything takes time. So what I have decided is that once we go through all of these courses, then we will design a few courses in which we'll just go through them as long cases, etc. Mix and match of cases. But having said that, one thing you have to remember, this kind of a case has come in the exam many a times. They will show you what we call tumor thrombus in the portal vein. And you will be, because you are thinking it's enhancing vessel, then you look carefully. Look at this case. This is an arterial phase. And on this arterial phase, you can see the portal vein. Why should you see the portal vein? Either there will be a shunt. There was no shunt in this case. Actually, this is a tumor thrombus. And tumor thrombus because it has gone into the portal vein, grown into it, and this case was a cirrhosis with HCC. Okay, candidate 3. So in this case, we picked up 2 incidental focal lesions, 62-year-old male. One was this, one was that, and then we did an MR. Over to you.
These are selected MR slices through the liver in different phases. So on the you labeled them as well. So, so the lesion in question is in the left.
Okay, so what? Let me just guide you that actually on MR 4 lesions were visible, but I'm just showing you one lesion, which is this one. Just describe this lesion, please.
Okay, so the lesion is T2 hyperintense compared to the rest of the liver, and T1 hypointense. While on in and out of the phase, it loses its intensity. So there is some signal loss, intralesional patchy signal loss within the lesion.
So you think it's fatty, right? Okay, good.
Yeah.
A bit of restricted diffusion, right? Still bright on B1200. Bit of restricted diffusion, and then I show you contrast.
So on contrast, there is some enhancement within the lesion.
So what do you think? It is, benign, malignant. Where are we?
There is some. So I can't see any washout on this first thing which I've noticed. So there is a gradual contrast enhancement rather than washout.
The word washout means, please remember that washout means, there are 2 different things which you have to look into this case. What is happening inside the lesion, but vis-a-vis parenchyma, what is happening? If you see parenchyma, arterial phase, parenchyma is enhancing. Within the lesion, there is just a bit of enhancement. Rest is not enhancing. It never becomes equal, but within the lesion, there is a bit of an delayed enhancement. So there might be, let's say some component which is enhancing. But with restricted diffusion, with this kind of finding, what do you think it can be? And the idea is, that it has got fat. So what can have fat?
SCC. SCC is my top differential here. Hepatocellular carcinoma.
So it is totally fatty, actually. So this is actually a long case, which, of course, I had not shown you other bits. This is on a CT scan, it becomes very impressive, where it had fatty change, just like this MR, and there was a liposarcoma sitting here, incidental. So this is a type of a long case. Of course, I did not show it to you as a long case, but I wanted you to keep an eye open for fat-containing lesions. And metastasis from liposarcoma in the liver have come in the exam. And this is the idea to show it to you. Liposarcoma metastasis. Okay. So this patient is post-trauma, and there is a laceration here. On limited CT scan, there was a lot of upper abdomen, this fluid, loculated fluid. And what should you be worried about?
So the bleeding, the density of the bleeding is not that. After 2 days, I mean, obviously, in my day-to-day practice, I would check the Hounsfield unit, but there's a lot of fluid.
This was not hemorrhage. This was not at all hemorrhage. This was like water.
Okay, so there's a lot of loculated effusion I'm worried about loculated ascites for whatever reason, whether the patient has got some pre-existing disease causing this loculated.
Pre-existing disease.
Sorry?
There was no pre-existing disease. There is a laceration hint. What comes to your mind? What else can happen?
One is bleeding. One is bilioma or
So
biliary leakage.
So biliary leakage, very good. So what will you do? How will you confirm it? Why was
So with biliary leakage, I would do MR.
Before that, how will MR help you, by the way?
MR will not really help, to be honest. I would do ultrasound scan.
Before that, how will ultrasound scan help?
Or fluoroscopy would help as well.
How will fluoroscopy help you? What will you do in fluoroscopy?
I mean, I was thinking of PTC cholangiogram, but
The PTC, can you do a PTC if intrahepatic ducts are not dilated?
no.
Yeah or no?
No.
Yes or no?
No.
You can never do a PTC. Please remember, if intrahepatic ducts are dilated, only then you can. And in trauma with lacerations, that and with, you should not do it in any case. But you won't be able to do it. The answer is, and this is a classical scenario, it has come in the exam many a times, this kind of a case. You have to keep your minds open about this, biliary leakage, where you just ask the clinicians to put in just tap it, send it to the lab, bile salts and bile pigments, and you got your diagnosis. Once you get the diagnosis, then you have to image it. And for imaging, you have to do, what is this? What procedure has been done? Candidate 3?
Yeah, ERCP has been done.
And leakage or no leakage?
There is leakage.
Right. So basically, I have seen it many a times that many of the candidates have used, I will do an MRCP. Now, please remember, you need a dynamic cholangiogram to diagnose it. Two kind of cases will come in the exam. One is post-trauma, like the case which I showed you. Another one will be post-surgery. Dynamic cholangiogram is, you can do an ERCP, just like this case or this case. You can also do nuclear scanning, HIDA scanning or DESIDA scanning. But you can also use a new technique. And this is, I think, a distinction type of an answer if you want, where you can do a T1 weighted MRCP with HSA, hepatobiliary specific contrast. What we do is that if you see here, go back to the basics, that 50% of it is excreted by the biliary system. So actually, it will be excreted through the biliary system. And so this is the gallbladder. And the technique which we use, I have got an experience of about, I think, 12 or 13 cases which we have done. And this is very very unusual to do it. We will only do it if we cannot do the other bits. So this is not the answer for your FRCR, but it might be a distinction question or a scenario where you can impress the examiner by your knowledge. Basically, nuclear scan is up there, but if nuclear scan is not there, ERCP you can do, which is a bit invasive. And you can also do this technique if both are not available, or for some reason you cannot do an ERCP. Please remember, MRCP or PTC is the wrong answer. MRCP is a T2 weighted MRCP. There will be fluid inside the biliary system. There will be fluid outside. How have you confirmed that there is a leakage? You cannot confirm. It has to be a dynamic cholangiogram. And similarly, PTC, of course, PTC you cannot do without dilated ducts. So for this, what we do is that we do about 60-minute delay. Instead of 20-minute delay, we give it more time and it will excrete. I'll show you an example shortly. We've done about 12 or 13 cases, and only in 3 or 4 we were able to answer the question. In others, we were not. But to delay it further, you might get more better answers. This is your last case, candidate 3.
These are selected CT slices through the liver in different contrast phases, from the right to the left, arterial to delayed, which is demonstrating on arterial phase there is hypoactinated lesion in the right lobe of the liver, which is demonstrating peripheral nodular. There is a continuous enhancement, but there is more nodularity to the rim of it, and there is a centripetal pattern of filling on the delayed image. There's no capsular retraction associated with it, and so my differential here, my thought process was to that this is representing a benign hemangioma.
Okay, good. So if you see here on arterial phase, it does not show much enhancement. It can at times also. Then you picked up well. In this particular case, we did a few delayed phases, and this is what we used to do before the MR world. And you can see this nodular enhancement, which has occurred slightly in a slightly late phase. And then initially, you have to remember that there is nodularity, but it is not continuous. Number one. Number two, look at this enhancement, and you will agree that this enhancement is equal to the blood pool. Look at this phase. Now the nodal, there is a bit of centripetal extension, and again this is equal to the blood pool. Look here, it is completely centripetally extended to the center, and it is equal to the blood pool. So this is a classical hemangioma. Okay, thank you very much. And candidate 4, are you with us? If candidate 4 is candidate 5, are you with us? Raise your hand, please.
Hello?
Okay, I can actually. 4, yes. Yeah. Okay. So this is a case in which ultrasound, this is an ultrasound exam, 62-year-old, this was the lesion. So we did MR, and you just comment on these sequences and then I'll show you contrast. Over to you.
Okay, so I've got MR series, axial slices. The lesion is hypo-intense on T1, hyper-intense on T2, hyper-intense both on ADC and DWI, which would indicate kind of a T2 shine through rather than a genuine diffusion restriction. The lesion becomes more apparent on the coronal T2 that there is kind of more of a has.
Okay, so that's fine, and now we have gone to contrast.
So now we've got contrast from the left to right, from non-enhanced through to delayed. There is some peripheral enhancement starting in the venous, then some intralesional definite enhancement within the centre of the lesion at 3 minutes, 5 minutes, and to the point at 10 minutes where there's kind of the most maximal enhancement of the lesion. So in summary, this lesion is more kind of enhancing predominantly in the delayed aspect of the contrast series.
Conclusion?
My concern is that this represents a intrahepatic cholangiocarcinoma in this context.
And why isn't it a hemangioma?
Pardon?
Why isn't it a hemangioma?
It's not a classical centripetal fill-in, so it's not peripheral then going centrally. It's centrifugal.
Okay,
more.
so, right, okay. So the point is that this is a giant hemangioma, and giant hemangiomas are by definition more than 10 centimeter. And giant hemangiomas, you see, it's quite big, right?
Yeah.
And it is bright on DWI. It now, if you see the contrast enhancement, of course, maybe you are a bit handicapped because you are just getting one slice. There is there is actually a nodular enhancement here. It is less, more so, then more, then more, and then more. A large portions of a giant hemangiomas might not enhance. Please remember that. And there might be scarring, and some people say that there might be some thrombus sitting there. So large portion might not remain unenhanced. Even here, the same formula of is it equal to the blood pool, you have to remember that. Look at the enhancement pattern, and you will agree even on this late phase, it is equal to the blood pool. Look here, and it is equal to the blood pool. Look here, and it is equal to the blood pool. So this is another giant hemangioma. Now, why I'm showing you a giant hemangioma, that it has come in the exam quite a few times, and many people confuse it for the simple reason that they have not seen it, and in their usual practice. This is another giant hemangioma where on a T2 weighted sequence versus a highly T2 weighted sequence, it is brighter here. Uh, then look at this enhancement, which is peripheral, and then of course we have not the late phase, we don't know if it is 10 minute or whatever, but a large portion might not enhance. That doesn't change anything. So this is still a giant hemangioma. Okay, candidate 4. So this is a 36-year-old female, came to A&E with acute abdomen. Oh, sorry, I've sorry, written the diagnosis there. So maybe I'll just tackle it as a teaching case. Now, if you see here, this is a classical case again, which has come in the exam, where a patient they will show you a CT scan like this, and you will say that there is an intraparenchymal hematoma, and this is in keeping with trauma or whatever. And then will come this bombshell that there is no history of trauma. Or you will ask the examiner, and the examiner will say there is no history of trauma. So it was spontaneous. And this is what I wanted to show you for the exam. Spontaneous liver hematoma, particularly in young female like this. Please remember adenomas, and the patients will come to the A&E with bleeding. So this is, picture, and this is a similar case. I have already showed you this case in which I showed you the capability of hepatobiliary specific contrast to differentiate between an FNH and an adenoma. And if you remember, this case has 2 arterially enhancing lesions, and they did not show any washout, so we were happy that they are benign. Then on the hepatobiliary phase, one retained contrast, so this was an FNH, another one lost contrast, and this was an adenoma. Just to make a point that here, this patient is a 29-year-old with glycogen storage disease, and this patient is she had 6 adenomas actually, and this is one of them which I am showing you on these slides. Okay, candidate 4. This patient, you are doing an ultrasound scan and you have picked up sort of ascites. What is happening here in the liver?
There's scalloping of the liver.
Excellent. So what comes to your mind? Will you highlight this in your report, or you will just sort of
concerned about kind of peritoneal carcinomatosis, also a process that's causing deposits on the liver that is then causing extrinsic compression scalloping.
So this is a CT scan of the similar anatomy, so what you saw on ultrasound, and I'm also showing you a T2-weighted sequence. So with this appearance, what comes to your mind? You're absolutely right, this is scalloping, but I just wanted to listen to a word there. Basically, how does it happen? Because you see, the argument is that there is nothing sitting there, nothing, no soft tissue or any mass sitting there.
Mm.
So, there's a word which, anything comes to your mind regarding appendix or ovary and...
Mucocele, so it's...
yeah, close. You are there?
Where is it?
Okay, so the word is not coming to
There we go, pseudomyxoma.
Here you are, I knew it. Yeah, good, well done. So this is pseudomyxoma peritoni. And pseudomyxoma peritoni, of course, the most common, and it can come as a long case, please remember. Basically, there is this mucoid material which fills up whole of the peritoneal cavity. And the key thing in the exam will be scalloping on the outer edge of the liver. Radiologically speaking, this will just look like ascites, but that scalloping is what you have to pick up. The most common cause, by the way, is appendix, tumor. So look at the appendix very, very carefully. And it might be very small, and everything otherwise will be very large. Similarly, look for ovaries. In this case, this was an ovarian lesion. It can also come from colon, but appendix is most important for the exam. Appendix. Another case of pseudomyxoma peritoni, that scalloping is the main thing which I wanted to show you. Another case, but this one is slightly different, because in this one you can see some soft tissue also there, but usually you will not. Pseudomyxoma peritoni. Okay, candidate 4. Now, T2, T1 pre-contrast, DWI, what do you think it is? With pain, abdomen and fever.
I think this is a hepatic abscess because I've got central low hypo-intensity on T1, hyper-intensity on T2, and then with an enhancing kind of capsule and borders and restricting borders.
Yeah, so this is a abscess which shows restricted diffusion, and on contrast it showed enhancement, some septations, etc. This is an interesting case, and actually this was a fish bone which had gone spontaneously into the liver, and this is reported in literature. This fish hypothesis is that the patient actually ate it, and it just penetrated, it went to the stomach and then penetrated through the stomach into the liver. And case reports are there where fish bones have even gone into vessels, and they've gone to some other part of anatomy through, going into the vessels. So this is an interesting case. Last case for you, and then candidate 5 should be ready. So this patient came to the A&E, and what do you think?
There's increased density within the right upper quadrant and depression of, so the gas pattern within the right, the hepatic flexure is kind of pushed inferiorly.
Mm-hmm. So what will you do?
So suspicion that there's hepatomegaly. In the first instance, in a 24-year-old, I would do an ultrasound scan.
Excellent, very good, because if you had asked for a CT, I would have stopped you there. So that's a very good answer, and this is what they want to hear in the exam also. On ultrasound, can you characterize this? Characterize means have you got a black and white answer or no?
don't have a black and white answer.
Okay, CT scan. Have you got a black and white answer?
That in combination with the CT, I'm worried whether this is kind of a high dated cyst and there was cysts to cysts that were more.
Excellent. How can you confirm it?
The patient should have a eosinophilia within their blood screen. I don't think you don't want to biopsy them or aspirate them because it can cause a kind of hypereosinophilic and anaphylactic reaction.
Okay.
So
imaging wise, would you do anything else? Or would you
do an MR?
So this is the MR.
So
I will, because of time factor, I'll ask you leading question. Confirmed or not?
Yes, I think so. Confirmed.
Okay, so these are internal membranes. Please remember, hydrated cyst. Thank you, candidate 4. And candidate 5, I'll ask you to raise your hand in a while. Hydrated cysts are important for the exam. Many scenarios in which even brain, chest, liver, wherever, peritoneal, all of them have come in the exam. There are many features of hydrated cyst, and sometimes they can give you on some imaging, they can give you pseudo-solid type of an appearance like here, right? And this is internal membranes. You can see those subtle membranes here, but generally speaking, it looks like cystic. And then on MR, it is there. So the Viva questions are that you can ask for serology for hydrated, and biopsy. Of course, classically we were always told not to do a biopsy. There are some studies in the literature which tells us that people have done 70 odd biopsies and nothing happened, but some of the other, this concept still persists. Don't put a needle inside. So that is fine. So candidate 5, are you with us? Can you hear me, please?
Yeah.
Okay. Now, is the liver normal?
No, it's abnormal. The density of the liver is quite high when compared to the spleen, so it's hyper attenuating. I could think of possible causes as amyodrone or iron
So
overload.
liver density, right? So it is abnormal. Very good. So the point is that this is from your last Chapman CT liver generalized increase attenuation on pre-contrast study. Now these are points to remember. Normal liver is 40 to 70 Hounsfield. Usually it is 45 to 65. Normal liver is 7 to 8 Hounsfield more than the spleen. In hemochromatosis, it can be anywhere between 75 to 130. And if liver density is less than spleen, then it might be fatty liver. So the idea was to show you this increased density. Okay, candidate 5. Rule out hemochromatosis. This is what they want to ask you. They have given you T2 weighted sequence. What do you think? Is there hemochromatosis?
So these are T2 weighted MRI sequences. The liver is hypo-intense compared to the spleen, whereas the pancreas is within normal range and is actually, I'm just having a look at the pancreas. Looks okay, I think. So it is the density of the liver is low, the intensity. So I would say yes, it is hemochromatosis.
And why do you say it is low? Have you got a criteria? Have you compared it with something, let's say with the muscle or something like that?
Yeah, it's usually with the muscles that you compare with. But actually, looking at back, it looks very similar to the muscles. I can only see the the paravertebral muscles here. But it just, I don't know. To me, it looks slightly hyper intense.
So can you confirm it on what we'll do? How will you confirm it? Basically, I'm asking you, do you want to do any other sequence which will be more specific?
You can do gradient echo.
So this is not the same case, by the way. This is not the same case. This is another patient. But just on this patient, what is the sequence and what is your conclusion on this case?
So this looks like a T2 star gradient echo, and I would say this is hemochromatosis because the liver is hypointense compared to the muscles I can see.
Okay. This is another patient, and so I have given you sequences. Can you describe the findings and the conclusion? Why, is it hemochromatosis? It is not hemochromatosis.
So T2 star demonstrates hypointense liver compared to the surrounding muscles, and the in phase out phase is opposite to what I would see in a fatty liver, suggesting there is iron overload and in keeping with hemochromatosis.
Excellent. Okay, so I take over now. Basically, when you hemochromatosis is an exam case. It has come in the exam. They can show you hemochromatosis with cirrhosis, with HCCs, with, pancreas was a good pertinent point which was pointed out by candidate 5. You have to see if pancreas is involved. If heart is visible, you have to see if there is something going on there also. Having said that, basically what we do is we do a T2 weighted sequence, then we do gradient echo sequence. This is a protocol which is what I call the French protocol. They did a lot of work on this. Here we, in our department, we do various kinds of TRs and TEs. You don't have to remember all of these, but we have increasing gradient, echo TRs and TEs. So it becomes blacker and blacker and blacker. So this is the most sensitive sequence. In this particular example, even on T2, you can see that this is darker as compared to the muscle. But the answer is that gradient echo is much more sensitive. And as was pointed out, that you do in phase and out of phase. And on out of phase, if you see this out of phase, this is brighter as compared to this one, which is what you expect to be seen on a fatty change. Now, I am going to show you a few cases which are in sort of a PACS type of a format. Candidate 5, just to make sure that you are seeing what I am seeing. Is there a red slide on your eye in front of you? Case 1? Yep. Okay, so this is not a Viva case. I'm just going to teach you on this. I put in 4 or 5 cases just to teach you. Now, this patient is, I have selected a case here to show you biliary leak in a 42-year-old female post-cholecystectomy. So what happened was that this patient, after the cholecystectomy, was this was the MRCP, and they had put in a drain. So you can see the drain here. You can see that part of the common hepatic duct level is not visible, but that might be because of edema, etc. So there was a lot of fluid and etc. coming out. So there was a bit of bile there also on lab analysis. They knew that something is there. They put this drain there, and then after a while they thought, or they wanted to make sure that there is no further leakage. So, and for some reasons, they could not do an ERCP, and at that point, nuclear scan was not also available. So we did a hepatobiliary specific contrast MRCP. So on a T2 weighted sequence, this was the anatomy. You can see this drain here. This is the gallbladder fossa. In this gallbladder fossa, there is a bit of fluid. So you don't know this fluid is, active bile or not. This is the main point, right? So then we have got, this is 20-minute delay post, hepatobiliary phase. So this is 20-minute delay, and you can see that on a hepatobiliary phase, this is how a liver looks like in 20 minutes. You know, the vessels, etc., are not all that bright, but parenchyma still retains something. On this 20 minute, within that gallbladder fossa, you can see something there, and this is that, you know, that what we call the drain. So you can see something there. You think, oh, something is leaking into this. So what you do is you do a further delay, and this is a 60-minute delay. You know, administratively speaking, it's a big ask. For either the patient has to be on the table, or if it is not on the table, then you can scan somebody else and then bring the patient in. Now this is that drain, and you can see that even this drain looks a bit bright now. So what is happening? And if I am, as we are tracing it backwards, now you can see here that there is contrast pools in the gallbladder fossa. So you have made a black and white diagnosis that there is a biliary leakage. And this is the capability, one of the capabilities of hepatobiliary specific contrast. Right, let's see if I've got, okay, this is a case of, multiple hemangiomas, right upper quadrant pain, gallbladder. So this one on ultrasound was bright, means it looks like a hemangioma, but this is slightly atypical on ultrasound appearance. It is not bright. So on a T2 weighted sequence, look here, this is bright. Another one is here, another one is there. So B600 and bright. So the another one maybe here, maybe here. So there are multiple hemangiomas, and on B1200 still they remain bright. Now on arterial phase, now this is that nodular enhancement I was talking about. You see on this lesion, see that there is enhancement, and this is in the periphery, and this is nodular. It is not continuous. And some nodularity here, some nodularity here, some nodularity here. So, and look at this lesion, and again, there is nodular enhancement and discontinuous here. So this is, and look at the signal. This signal is equal to the blood pool. So, and gradually it will fill up. So now it is filling up, and this one is also filling up. And again, look at this signal versus this signal, blood pool. It is the similar signal, and then it has filled up further, and it has filled up, signal equal to the blood pool. Now, this is, you know, the late phase, and you are worried, is it washed out? Because the signal is less than the parenchyma. Is it washed out? Then you look carefully and look at the blood pool, and the vessels are also similar. So the key thing is, on all sequences, the signal should be equal to the blood pool. Look here, this one. And again, look at the IVC, look at the portal vein, it is equal. So, you know, there are so many parameters on MR. It's a beautiful tool. You use all of them, and you are very confident of your diagnosis. And 10-minute delay, similar to the blood pool. So this is a case of, what was this? Multifocal HCC. This patient had cirrhosis of liver, 6-month routine ultrasound, but alpha-fetoprotein was increasing. On ultrasound, this was the picture. We were not confident of picking up a focal lesion, but on MR, on T2 weighted sequence, there were a few doubtful foci, but the key sequence, of course, you can see cirrhosis there. The key sequence on diffusion, there was a bit of restricted diffusion. For example, here on arterial, look here, 1, 2, 3, 4, 5. I think there were 8 odd lesions, if I'm not wrong. And so they enhance. So this is the key finding in HCCs, that, and then there should be a washout. You see, it becomes black as compared to the parenchyma, and all of them, they become black. So this is the criteria to diagnose HCC. Look, this one is also becoming black. So, and they are beautifully seen here as, so this phase is 20 minutes. And this tells you the second, you see, this is a 20-minute delay, and because HCCs, there is no normal hepatocyte, it will become black. So your confidence level really increases. So this case is a case of, the what we call HCC, which is causing tumor thrombus. If you see this CT scan, this is an interesting CT scan where you don't see the portal vein, you see this tumor which is going into the vein. You can, stretch your imagination that this is the portal vein. There is collaterals around it, cavernous transformation type of a thing. Even here, the tumor is going in. But we have got a venous phase here, so we did not have an arterial phase. On arterial phase, there is a bit of enhancement here, but the key thing here, which I want to show you on venous phase, this is it. Again, you are not sure if there is tumor or whatever. And look at this, T2 is very good. It shows something is happening. But look at the diffusion. Diffusion was brilliant in this case. You see how beautifully it highlights. And this is an exam case, and it has come in the exam many a times. Tumor thrombus. On ADC, it shows restricted diffusion. So this is a case of pyogenic cholangitis. And this case, on a CT scan, there was, previous surgery, there was a stent, etc. The patient developed fever, etc. There were things happening on this CT scan, but on diffusion, now this time the diffusion has picked up abscesses. So look at this diffusion, and you can see that within the intrahepatic ducts, because the ducts are dilated, then with that there are what we call micro abscesses. So everything is showing restricted diffusion. So another use of suppurative cholangitis, and you can see this on MR much more beautifully than the CT scan. Okay, so I think what we'll do is that we will take a 5-minute break, and after the break, candidate 5, thank you very much. It will be candidate 6 after the break. Candidate 6, are you with us? Can you raise your hand? Okay. Candidate 6.
Hi.
Right. So because of time factor, I'm going to ask you leading question. What is the examination?
MRCP.
Okay. What is the examination?
ERCP.
Sure.
No, sorry, angiogram. PTC.
PTC. Okay. A few points for your exam regarding PTC. Please remember that this needle might be there or might not be there. You can just remove the needle and then take the film. So don't think that the needle will always be visible. And another point to remember is that PTCs can only be done when there is dilated intrahepatic system. Otherwise, you cannot do it. So this is a PTC. On the other hand, what is this?
ERCP.
Okay, so in ERCP, the endoscope that will always be inside the cobra. I call it the cobra. You can see it inside. So they have to be in this position to be able to give you the films. So this is ERCP. What is this?
Is this a direct cholangiogram? I can see a catheter in the biliary tree.
What is the shape of that catheter?
It has a 90-degree angle to it within the duct.
So there is a word which is it coming to your mind?
T shape, not sure.
Excellent. T shape. So T tube cholangiogram. Basically, T-tube cholangiogram is a scenario where the surgeons might not be happy that during the procedure they will be worried about something. For example, that if a duct is going, a stone is still there and things like that, or they're suspicious. So they put in a T-tube. It comes out of the body, and after a few days, you can do a T-tube cholangiogram where you can just put contrast through it and then take films. So this is a T-tube cholangiogram. So this is maybe 7 days afterwards, because the teaching is don't do it very early, because there might be some hemorrhage hematoma sitting inside which will appear as a filling defect, and you might diagnose it as cholelithiasis. On the other hand, what is this candidate 6?
So it's another direct cholangiogram, but the tip isn't T-shaped this time.
So
Not sure.
okay, so this is peroperative cholangiogram. You see what is happening? This is a cystic duct, and basically they have gone in and just opacified. This is known as a peroperative cholangiogram. So this was a T-tube. This is a peroperative cholangiogram. Okay, so this is a viva film for you. What is this, and what is the diagnosis?
Okay. So this is a T-tube cholangiogram, and the ducts appear to be dilated, and specifically the left and right common hepatic ducts appear to be slightly beaded in appearance. The CBD appears slightly dilated, and there may be a filling defect in the distal CBD. My primary differential for this would be primary biliary sclerosis.
Primary biliary sclerosis. Okay, so you see, this is a T-tube cholangiogram. What is happening here is that there is a filling defect here, and this filling defect, there is a meniscus sign. Remember this. This is known as a meniscus sign. Then, more proximally, this is all, of course, it is dilated, but, there are no other signs of any other stricture formation, etc. So you might be getting confused because there is a duct system which is projected on this duct system, which is projected on this, and this you are getting this pseudo beaded type of appearance. It's very simple. This is a T-tube cholangiogram with cholelithiasis, a retained stone there, and that was the purpose of this T-tube cholangiogram. And I want you to remember this meniscus sign. Meniscus sign. Please also remember, as far as biliary system is concerned, never ever consider it like a barium study, the signs of overhanging edges and all those things. Don't even go into that territory. The findings here are totally different. But this meniscus sign is an important sign for what we call retained stone. So one thing for the exam is, and this is a very useful tip for the exam, that when you find biliary strictures, there can be 3 different levels. So this is the CBD, this is the porta hepatis, this is the left main hepatic duct, right main hepatic duct, this is a PTC. If the obstruction is at this level, in your exam, the most common top three differentials here will be cholangiocarcinoma. This cholangiocarcinoma is what we call the flat skin tumor. Of course, then portohepatitis metastasis, as in lymph nodes, etc. Gallbladder carcinoma can also cause this. So, maybe more common than portohepatitis metastasis, actually. Then, in the middle portion here, the differential diagnosis will include cholangiocarcinoma and pancreatic carcinoma. If you stretch your imagination, if the pancreas is sitting here, this will be the head. The head will come here, and this will be the neck. So a tumor of pancreas in this region can cause mid hepatic duct stricture. And so these will be your differentials. Cholangiocarcinoma, it will enhance on arterial phase, or even on venous phase it might enhance. Pancreatic carcinoma will not enhance. This enhancement pattern is difficult, and when there is enhancement with the pancreas enhancing, you might not pick it up. But in an early arterial or a portal vein, at times you might see enhancement there. This differential diagnosis is important differential diagnosis for the exam, where these two will remain the same. This one, cholangiocarcinoma and pancreatic carcinoma. So pancreatic and cholangio. But then carcinoma of ampulla of water, histologically speaking, this is different. And then duodenal carcinoma. So all of these things should be in your mind. And please remember the double duct sign. If the pancreatic duct and the CBD is dilated, go for malignant. These two are exam strictures. They have come in the exam quite often. Post-surgical, if you see, this is the cystic duct. And classically now, of course, they use laparoscopy and the techniques of the surgeons are very good. But having said that, still, when there is open cholecystectomy, this can happen. Simply imagine that if this is being tackled with an artery forceps and there is an injury here to the main CBD, then what will happen? That there can be later on fibrosis and there can be a post-surgical stricture. So this will be a benign stricture, which will be a shelf-like stricture. Chronic pancreatitis, on the other hand, there will be tapering here, and with that you might find calcification. So these levels are important for the exam, and whatever is it an MRCP, ERCP, or PTC, the differential will remain the same. Yes, please.
Okay, so this is a spot image of a PTC. I can see multiple clips where the gallbladder would be expected.
So this was long-standing post-cholecystectomy. We know that.
Okay. There's a smooth stricture in the proximal bile duct, which more distally tapers to normal caliber. So my top differential for this would be a post-surgical, post-cholecystectomy stricture.
You see, it's a long stricture. It's a long stricture. Post-cholecystectomy, that will be just a shelf-like. It's a long one. And this is a PTC, so your differential has to be that malignant. Cholangio versus gallbladder versus this. I'll show you a post-cholecystectomy, which will be a very smooth and, just a focal stricture. Okay, this is a MRCP, MIP of MRCP. And so can you describe this to me?
So the intra and extrahepatic biliary ducts appear to be dilated.
And what's happening to the pancreatic duct?
The pancreatic duct is also dilated.
So what is your differential?
So I'll be concerned about a pancreatic head cancer or a distal CBD lesion, such as a carcinoma of the ampulla or vata.
Is it distal? Is it mid-level? This thing. Is it mid-level or is it distal?
So it will be distal since it's affecting the pancreatic duct and the
No, you see, excuse me. What happens is this is the mid, this is the mid, this is the distal. The distal will be next to the duodenum. So if you see here, this is the duodenum. Now, what is happening is, if you stretch your imagination, the pancreas will be sitting here. This is the neck of the pancreas. So you are right, the lesion might be at the head or neck. But what is this? Is the mid CBD. This is not the ampulla. And in mid CBD, it is causing obstruction of the pancreatic duct. It is causing obstruction. So this is the cystic duct where it is joining the CBD. And this is where the lesion is. The lesion is not here. So if the lesion was here, then the pancreatic duct would have come all the way. Are you with me?
Yeah.
So just a fine bit, but that fine bit is important to get full marks, because the fine bit is that here the differential is pancreatic carcinoma and cholangiocarcinoma. Here the differential will be different. Here you asked for it. Now you understand what do you think about this one?
So the CBD and the pancreatic duct is dilated right to the distal aspect.
Yeah.
And there appears to be a filling defect next to the duodenum.
Yes.
So, yeah.
So this is classical that double duct sign, and this is at the ampulla. And here the differential will be cholangiocarcinoma, pancreatic carcinoma, so ampulla of water, and duodenum carcinoma. Thank you. And candidate 7, please. Are you with us? If you can raise your hand.
Hello, can you hear me?
Yes, I can hear you. So, what do you think is this? Which kind of structure?
It's a spot image from the MRCP, and this is a well-defined projection-like structure in the mid part of the CBD. And I cannot see the gallbladder or the cystic duct, so I would assume it to be a post-surgical shelf-like structure.
Right, but a bit of fine touch. I think you meant PTC. It is not an MRCP. It is a PTC.
Sorry. Yes. Sorry.
Yeah. So another thing is that if you look carefully, look here, left and right hepatic duct. So this is just distal to the. It is not exactly the mid. The mid is somewhere here. It is more proximal than that. So otherwise, fine. So this is a classical shelf life, which is post-surgical. And what is this?
So this is another spot film from PTC, and there is significant dilatation of the intrahepatic biliary channels and CBD as well. And then there is a very long stricture in the distal part of the CBD.
So conclusion.
Going up to the duodenum, but I cannot see the pancreatic duct dilatation otherwise. So my differential at this level would include a pancreatic carcinoma or a cholangiocarcinoma.
First of all, do you expect to see the pancreas on a PTC? I mean to say pancreatic duct.
No.
No, right? So second thing is there something else sitting around the distal CBD? Look outside. This is a classical exam case.
I can see some faint opacities around.
So, stretch of imagination, conclusion. These are calcifications.
Calcifications could be, yes. Yeah, so this can be due to the surrounding calcifications or pancreatic calcifications.
And conclusion.
Or chronic pancreatitis.
So this is a classical stricture of chronic pancreatitis, where you see the evidence of hair, and it gives us a smooth tapered type of an appearance. A malignant stricture will stop here. This is too classical in the real world. Chronic pancreatitis is a nightmare to differentiate. Particularly, we know that at times there is superadded carcinoma also, because it is associated with chronic pancreatitis. But this stricture, if you read in your textbooks, smooth tapered appearance is how we describe it. And with that, this is classical chronic pancreatitis. If you see this picture, and this chronic pancreatitis here, post-surgical up here, and this is the mid. Spot diagnosis, what is this? What is this black thing?
Okay, so these can be stones. This is the
which car comes to your mind?
The classical, yes, the Mercedes-Benz sign with the facet. Yeah.
Very good. So this is known as Mercedes-Benz sign. There are stones, cholesterol stones. Don't think that this will be seen in each and every stone, which sit in the gallbladder, and the fat is hypodense and gives you this kind of an appearance. Mercedes-Benz sign. Okay, now I will skip this. All of you can understand what's happening, but many a times these kinds of cases have come in the exam, where they will show you an ultrasound of gallbladder or choledocholitis, and from there they will take you to another film and things like that. So just to highlight that ultrasounds have come in the exam many a times, but I'm sure you will pick that up. So this is PTC, where now the needle is not shown. What is your diagnosis?
So I can see some filling defects within the gallbladder consistent with gallstones, and then I can see the dilated cystic duct filling defect within the neck or cystic duct, and then further down there is a very well-defined filling defect at the distal end with a meniscal sign. So this would be in keeping with choledocholitis with
stones. So very good, well done. This is easy and similar findings, but different case. And here you can see that there is a stone here. There are multiple stones in the CBD. There are stones in the gallbladder. Nothing special in this case. Yes, please.
So I'm presented with selected CT images, portovenous phase, contrast enhanced. The most significant abnormality that I can see is intrahepatic biliary channel dilatation involving both right and left lobes. And if the gallbladder is also a bit distended with mild pericholecystic edema as well. So if I'm trying to trace the CBD, do not particularly see significant dilatation. Okay, this is, yes.
So what is this?
So there is a bit of enhancement within the dilated CBD.
Right, so?
This would suggest that there is an enhancing lesion within the CBD, which would be enhancing mass, or otherwise.
How can you discriminate between enhancing mass or stone?
I would like to see on a plain CT the density of it.
So that was the idea to ask you, and on a plain CT, it remained like this, right? And then it was a stone. Basically, why I showed you for the simple reason that in the exam they have shown these kinds of cases. Please remember, in the pancreas we did hyper-enhancing pancreatic lesion, as in gastrinomas, etc. And they might show you enhancing lesion, and it can be a pitfall. So this time I have shown you a stone actually, and you have tackled it fine. That it might be, I want to see a non-enhanced image to be able to confirm it. In this case, it was a stone. Okay, so fever, right upper quadrant pain. What is your diagnosis? Can you describe it? What is this? This is what I want you to tell me.
Okay, so the patient presented with fever. So the gallbladder is very ill-defined with lot of significant surrounding edema and wall thickness as well, which is quite irregular. And I can see some discontinuity in the wall as well.
Okay.
I would suspect this to be a complicated cholecystitis with gangrenous or ruptured.
Okay, well done.
And then the this area, which is, I cannot see if it's adjacent to this, but in my normal practice would see if it's continuous. So this may represent an abscess.
Actually,
or a connection.
this was my question, that how will you describe this? If you see, it is enhancing. It is you. Otherwise, you have tackled it perfectly well. This is a phlegmon, and this is just inflammation, which is enhancing. Abscess you will call when it will not enhance. So this is otherwise it's perfect. There is acute cholecystitis with rupture, etc. This, on the other hand, is a painless jaundice.
So in this one, I see intrahepatic biliary dilatation involving the right and left lobe. And then within the region of gallbladder fossa, I do not perfectly see the gallbladder, but seems to be a mass lesion, which may involve the gallbladder itself, which is heterogeneously enhancing.
Conclusion?
So my conclusion will be a gallbladder mass, a neoplastic gallbladder mass, which is causing intrahepatic cholestasis.
Okay, so this is the ERCP of the same case, and basically, if you see that there is a stricture here, and then there is, if you see, this is the porta hepatis, and just distal to that. So this comes in the differential diagnosis, the level 1. The porta hepatis level, and this case demonstrates to you that a gallbladder carcinoma can actually cause obstruction at this level. Okay, candidate 7, thank you very much. Candidate 8, are you with us? Raise your hand, please. So,
hello.
Okay. Okay, now if you see, this is the gallbladder. There is a stone sitting in the neck of the gallbladder, which is here, and then there is intrahepatic duct dilatation. What comes to your mind?
Meredzi syndrome.
Okay, so what do you think?
Yes, this. So it's an impacted large stone filling defect with crescent meniscus sign in the gallbladder neck. It's compressing but not totally obstructing the gallbladder, the CBD, given the dilatation of the intrahepatic biliary tree, but there is contrast going down the distal CBD.
Okay, so Meredzi syndrome has come in the exam quite a few times. Any modality can be asked. Basically, the stone, if it is sitting in the neck, it can cause it. If it goes into the cystic duct, it can cause it. It can also cause erosion. So the stone partly might be sitting in the CBD and partly sitting in the gallbladder or the cystic duct. Look at this example. We are on MRCP, part of the stone is here and part of the stone is going into the... So basically what happens is that there is an erosion and there is in continuity. This is the MRI of this, and you can see this Y-shaped limb of the case which I just showed you, this case. And you can see part of the stone is sitting here, part of the stone is sitting here. So this can also happen. Yes, please.
So I can see evidence of previous cholecystectomy. I can see multiple dilated intrahepatic biliary radicals in the form of beading. I suspect this is might be due to primary biliary cirrhosis. I'd like to check the caliber of the CBD, because if the caliber of CBD is abnormal, this might suggest primary sclerosing cholangitis.
Primary sclerosing cholangitis. Why have you said that? Because of what? Beating. You mean to say this thing? If you see here, the biliary system. This is the biliary system. It looks fine. This film is an erect film. This is actually This is actually the CBD. There is a meniscus sign there.
Yeah.
So this is a PTC which has been done, and there is dilated system with this meniscus sign. So there is a stone. Now, with this stone, what do you think is happening?
Carolius disease, maybe?
Stone, okay. Let me give you a hint. Fever.
Cholangitis?
Cholangitis. So how do you explain these things?
Cholangitic abscesses?
Yes. So these are micro abscesses. And this is a tricky film because this is what we call pyogenic cholangitis. So various kinds of stigmata of pyogenic cholangitis can come in the exam. Pyogenic cholangitis is because of what we call obstruction, usually stones. There can be other causes also, post-surgical and things like that, particularly post-surgical when you have done, some kind of surgery. So this, you have to be, this is what is happening, that because micro abscesses are in continuity with the biliary system, that's why you get this. In this kind of a case, the viva will be sort of an interventional radiology type of viva. What can you do? And, questions, I will skip it because it has been covered in the IR section. But, and I don't know much about IR myself. I'm not an interventional radiologist. So the point is that the questions will be about PTBD, how will you do technique, etc. And look at this case. This was two weeks down the road, and now the micro abscesses are no more visualized, but stone is still there. Spot diagnosis. What's happening here?
It's emphysematous cholecystitis.
Excellent. So this is emphysematous cholecystitis, which has come in the exam many a times, and particularly on a plain film. This plain film I showed you before also. So this is a different case, and this is a different case. But diabetes is known with these. Right upper quadrant pain, fever. So you are a bit handicapped because you are, the same case. If I would have shown you an Osirex or a DICOM viewer, you would have picked it up. But having said that, just to guide you, this is the gallbladder. Something else is next to it. What do you think is happening?
Might be a liver abscess, might be a tumor.
Yeah. So with this kind of, known cholelithiasis pain, actually, you cannot make out. So let me demonstrate to you. Let me tell you that there is a stone here, and this stone was actually at the neck of the gallbladder. And with that, there is secondary abscess. So why I'm showing you, it is similar to previous case which I showed you. The point is the viva here will go into interventional radiology. So this is a acute cholecystitis with a liver abscess. What will you do next? What is the answer, candidate rate?
I put two pigtails, cholecystostomy and another pigtail draining to the abscess.
Okay. So before I show you that, this is coronal of the same case. And on coronal, actually, you can see this stone here where I'm pointing out. So the stone was at the neck, and there is a bit of misty mesentery, which can happen with any infective process. So The viva here will be, what technique, cell technique, etc., and all those things. Interventional radiology once again. So this is the pigtail, etc. And now, after 5 weeks, we have done a cholecystogram. So this catheter has remained inside. It was there for 5 weeks. If you see 5 weeks ago, the contrast did not go beyond this. Now, after 5 weeks, inflammation, etc., have subsided. What is your diagnosis here?
So there is improvement of the edema, and now there is communication with the intrahepatic biliary tree.
Anything at the distal CBD?
There is irregular short segment stricture.
Yeah, but I want you to, pick this up. Meniscus sign. You see this meniscus sign? Are you with me?
Yes.
There is a stone. That stone has gone down here. That is the point. The stone has gone here, so that was the main point here. What will you advise on this case?
Porcelain gallbladder precancerous for cholecystectomy.
Excellent. So porcelain gallbladder, which can also come in as a plain film. Please remember that it is considered a pre-malignant type of a condition, and we advise a elective cholecystectomy. Latest literature is not all that blatant. Previous literature told us a lot of percentages, but even now, take-home point is the practice has not changed. Yes, please.
Okay, this is a follow-through study spot image. I can see outside of its normal expected location in the right upper quadrant, related to the second part of the duodenum. I can also see small rounded or oval density projected on the right upper quadrant. Yes, this is the abnormal. And there is
here.
I think there is aerobilia too. There is a linear longitudinal, yes.
Yeah, but I'm not interested here. I'm more interested in what's happening here.
Okay, so contrast is reaching the biliary tree.
So what is your conclusion?
There is abnormal ampulla of water, which might be related to previous sphincterotomy. There might be...
what is this structure? This structure?
A fistula, duodenal biliary fistula, maybe?
Duodenal-biliary fistula. Actually, you are right. The point is that, please remember, this is a very important exam case. I think I have shown you a similar case in the past also. In contrast examination, barium, etc., fistulas are extremely important. Is the contrast sitting at the right place at that point or not? You have to, always look into that. Here, what is happening? This is a gallbladder, which is what we call a chronic cholecystitis. It is sitting there and it is communicating with the duodenum, and then contrast has gone here and retrospectively as gone into the biliary system. So your diagnosis was spot on, duodenal-biliary fistula, but this is the gallbladder. I can show you a CT scan of similar. Again, if I had shown you on a DICOM, you would have picked it up. Because this is not a DICOM, I'll just show it to you as an example. Now, if you see here, let me change my mouse. And this is very important for your exam. Same thing, 100% same thing, but this one is on a CT scan. The gallbladder here is contracted. It shows a bit of enhancement on axial sequences. This is the cystic duct, which shows a bit of enhancement. This is the duodenum. On an axial slice, you are not oriented what is what. So let me show you a coronal slide. Now on coronal, this is the gallbladder enhancing. You see, this is the duodenum. It is touching it. And now what is happening? So if I trace it from here, this is the coronal, so this is the stomach, the pyloric canal, and here do you see that there is thickening of the wall, and then this gallbladder actually is sitting next to it. And if you look carefully, there is actually a communication. Look, from here to here, the wall is thickened, and there is a communication, and this is the gallbladder. So if you see here, this is the communication. Classical, 100% like this case, though this is a different case and this is a different case. This is on a CT and this is on a barium. So this becomes a long case for you in the exam on a CT scan. Spot diagnosis, and what is your differential? Say again, please.
No, I was reading. Sorry. So I see this is markedly dilated gallbladder that is not high signal, with no high fluid signal.
So which examination has been done?
An MRCP.
MRCP. So, you go back to your basics, level of obstruction. What is the level of obstruction?
Cholangio, yes, it's a Klatskin tumor, Hyler.
Yeah. So, Klatskin tumor or Hyler. So, what will be your differential? One will be Hyler cholangiocarcinoma, second will be?
Gallbladder carcinoma, third
gallbladder carcinoma. Excellent. And third will be POTA, passive hepatic metastasis. Lymph nodes, right?
Yes.
Okay, well done. So, candidate 9, are you with us? Thank you, candidate 8. Just give me, this is a PTC examination, mid CBD stricture. What will be your differential in this case?
My differential would be cholangiocarcinoma or pancreatic carcinoma.
Excellent. Well done. "27-year-old, right upper quadrant pain, intermittent jaundice, and you see this thing. And with that, you see intrahepatic duct."
So I'm looking at these selected exercises through the upper abdomen. There is increased enhancement and thickness of the gallbladder wall with surrounding edema and a collection as well.
Excuse me. This finding, I'm not interested. This is a bit of partial volume.
Okay.
So don't worry about status, etc. What do you think is happening here and here? And 27, intermittent jaundice.
Yeah. So there appears to be a large low attenuation cystic area that is at the head of the at the region of the head of the pancreas, and there is intrahepatic biliary tree dilatation as well. So I'm thinking that there could be some obstruction, which is causing, and this lesion is causing some obstruction to the intrahepatic biliary tree as well. So
this is too much, isn't it?
It's very big lesion, cystic lesion, and it's just 27 years. So and this lesion hasn't got any solid component as well. There isn't any calcification within it. I'm thinking that this could be, based on the location, I'm thinking this could be a cyst within the pancreas, maybe.
And can it be a cyst of the CBD itself?
Yeah, it can be a cyst of the CBD as well. And this is like the choledochal cyst?
Yeah, okay. So this is an ultrasound examination of the same case, and this is an MRCP examination. So the point is that, you see, on a CT scan, it becomes very difficult, and you have to think what it is. Scenario is also, but let's revise the choledochal cysts. And out of these choledochal cysts, 3 of them have come in the exam very often. One of them is this is type 1, where there is fusiform dilatation of the extrahepatic, the CBD itself. This is a diverticulum of the CBD. This will not come, it's too difficult because of continuity, etc. It's very rare. So forget about this for the exam. This one again has come in the exam, and in good old days, it has come many a times on a barium examination. This is what we call choledococele. This is type 3, where this projects into the duodenum and it will appear as a filling defect. So this is a choledococele. Then this type 4A or 4B, in which there is, various combination of intrahepatic cyst with, this one is cystic duct. But by definition, at least the distal CBD, the extrahepatic CBD must be involved. And this one also has got this. This is, I think, more importantly in the exam, which has come, out of all of these, most common is type 5, which is Caroli's disease. And Caroli's disease has got intrahepatic duct dilatation. It will come as on CT scan because of some features which we will just cover shortly. And it can come on other modalities also. So I repeat, type 1, out of this, type 5 is most important. Type 1 is second most important. Type 3 is another one which has come in the exam. So let's see a few cases. So this is, which type is this candidate?
So this is type 1 because it's a fusiform dilatation.
Excellent. And what do you think is happening on this barium?
So in this barium, again, at the level of D2, there is, I can see that there's a defect, and I'm thinking that because we are doing the choledococele, this is likely a choledococele there, type 3.
Well done. You see, if you read old books of barium, 20 or 30 years old, certain, there is huge literature there. What differential diagnosis of filling defects in D2 segment on a barium examination. This time, in this era, that is obsolete now. But having said that, one of them is choledococele. Look at it, how beautiful it is. So what do you mean? What I mean is that the mucosal pattern, etc., is normal, and there is an indentation. And then on this, this is a per-operative. You see this? It is going here, and it has refluxed into the pancreatic duct also. You can see this choledococele. Choledococele, this distal end is, in old books, we used to call it cobra head appearance. Now, in the new books, we have changed the snake to adder head appearance, whatever you want to call it. This is an MRCP with filling defect. This is a type 4, and I just wanted to show you one from StatDX, because in type 4 there is intrahepatic duct dilatation and but by definition, excuse me, the extrahepatic duct will also be dilated. For me, it's not very important for the exam, type 4. Yes, please.
So there are multiple, there is dilatation of the intrahepatic biliary tree, and multiply dilated biliary channels are seen both in the right and the left lobe of the liver. I can't see any dilatation of the CBD. So I'm thinking this is likely type, this is the type 5, which is just the intrahepatic.
Okay, that's fine, because we are doing choledochal cyst, but in the exam you will have to slightly sit on the fence, because you have to make sure that all of these cysts are in continuity with the biliary system, right? So some of them are in continuity, and some of them you would like to. So I can, as the examiner, can just show you this exam, where you can see that they are in continuity. And by definition, type 5, one word you have to remember, usually this is secular dilatation. So it is, that's why it will give you this, a sort of a cyst type of an appearance, secular dilatation. So this has come in the exam quite a few times. And if you go back to the basics, candidate 9, what is this central dot sign? How do you explain this?
This is a starry sky sign, or
No,
because
no, no.
that's a vessel within it. That's why I'm seeing it.
Okay, so what is the concept behind it, and why is it absolutely
So
fine?
So what I'm seeing is that this is a dilatation of the biliary tree, and the central dot which I'm seeing is actually the vessel which is getting enhanced. So it's as vessel and the because the biliary tree and the vessel, they are in close continuity to each other. That's why I'm seeing it.
Okay, excellent. So basic concept is anatomy or embryology. Basically, you see the portal vein and the bile duct and the hepatic artery, they go together, the triad biliary. So what happens is when the biliary system is dilated, it actually sort of encases the vessel. And this is a very unique finding. It's an absolute specific finding. And if an examiner has got the CT in their, teaching files, they will show it to you because it's a very specific, and you will not see it in each and every case of Caroli's. So it can surround it. This is the central dot sign, and you have to give contrast to pick it up. Please also remember that this central dot sign might not be always central. It can be peripheral, which is common sense. For example, look at this one. It is to the peripheral, but you have to develop your eyes on this. And these days, I think if anybody wants to show you Corolli's, central dot sign is what they are going to show it to you. Agreed, central dot sign or not?
Yeah.
So this was a
it is central dot sign.
Trick question.
Okay, so there is dilatation of the vessel, of the biliary tree, and I can see an area of
Is contrast given?
No, contrast is not given. I can't see contrast.
Right. So you see,
it is not a central dot sign.
So what is this then?
So this is high attenuation, and so it is calcification.
Excellent. So the bottom line is this is still Caroli's disease. In Caroli's disease, you can get calculi within the biliary system, and this was the teaching point here. So don't get confused. This is an MR with this. This is cholangiogram with this, filling defect, and this was a non-enhanced CT. So with Caroli's disease, you can get what we call calculi also. So on this appearance, what is your diagnosis? Sorry, I had given the diagnosis there. So what is your diagnosis? Multiple small cysts, most of them about 5 millimeter or less. Few of them might be maybe 1 centimeter. 1 odd or 2 odd are slightly larger, and there are maybe hundreds of them. What is your diagnosis? Just give me the diagnosis.
So I need to see that whether they are being connected with the biliary tree. They're not. So they're not. So it's a there's a polycystic disease, polycystic liver disease.
Okay, so
autosomal dominant polycystic.
No. Let me tell you. This is what we call biliary hematomas, also known as von Meyenberg complexes, who I think in 1918 or 1916 or something like that, he actually described this. Don't confuse it with polycystic. There is a what we call autosomal dominant adult polycystic hepatic disease. Similarly, in liver, you can get the same thing with kidney disease also. There will be cysts. Those cysts will be larger. Remember that. They will not be as numerous. These are hundreds. These are, usually they are between 5 millimeter to 10 millimeter, and maybe less than 5 millimeter, most of them. And there is nothing else which gives you this appearance. And this is a classical case. So this is biliary hematomas. You did tackle it well. Will you say that I want to make sure that they are not connected, but this is not Caroli's. Caroli's will not be as numerous. They will be at times larger or slightly irregular. Fine. So this is biliary hematoma. Okay, now all of you, this is close to 9 o'clock. I'm going to show you two last cases, but these cases are extremely important for the exam, and a bit of clinical is there. There can be many long cases from these cases, and the concept should be absolutely clear. So I'm going to do a bit of teaching also on these cases. I know it's 9 o'clock, maybe I'll go 5 minutes beyond 9, but you have to concentrate on these. And these two cases, the radiological features at times are overlapping, but the clinical features and other investigations might be different. And all of these become viva questions. Those of you who are logged in from overseas, please remember that the FRCR exam, and this is why in the Royal College of Radiologists we use the word, this is clinical radiology, right? Clinical. So a lot of questions are clinical. And this example, the last two examples, I'm going to tackle PSC, primary sclerosing cholangitis, and I will compare it with autoimmune cholangitis, which is known as IgG4 related disease, IgG4 cholangitis. And these are extremely important for long cases, etc. also. So you have to concentrate on this, and this will also tell you that these kinds of management questions and viva questions which can come out of it. Now, because of the limitations that I'm just showing you limited scans, there is a bit of intrahepatic duct dilatation, 42-year-old male, 42-year-old male, note this, 4 weeks history of this jaundice. If you look carefully, this is the cystic duct which shows a bit of enhancement. If you look carefully, this is the CVD which shows a bit of enhancement. This is the CVD which shows enhancement. And this one. Now, if you see, this is the CT scan. So I can show you this CT scan in the exam, and you can see that there is enhancement here of the wall of the CVD. Even the gallbladder is showing up some enhancement. I am not showing you the intrahepatic ducts, but actually the enhancement went to the intrahepatic ducts. Now, with this enhancement, candidate 9, what is your differential?
So my differential for this is this could be ascending cholangitis. This could be
ascending cholangitis,
or it could be primary sclerosing cholangitis as well.
Okay, so this is just a close-up to show you this enhancement here, and then an ERCP. Can you describe it?
So on this ERCP, I can see that there is a contrast going through the CBD and also through the left biliary tree and right as well, and there is irregularity in the walls of the CBD, and it appears to be dilated from few parts and then narrowing at the other. So this is in keeping with the inflammatory changes or edema, which I was expecting to see because of enhancement we have seen on the CT.
So what is your conclusion?
So my conclusion is that this is inflammation of the biliary tree, that is ascending cholangitis in this case, because the patient has got symptoms of fever. And
you see, the point is that ascending cholangitis usually is secondary to obstruction, post-surgery, things like that. This case is primary sclerosing cholangitis, which can present with, acute the disease can have acute phases, etc. Now, if you look at this CBD is irregular, this outline of CBD, and then there is stricturing here, and then there is proximal dilatation, a bit of beading. This appearance is classical for primary sclerosing cholangitis. If you see this MRCP of the same case, there is a bit of stricturing here, some dilatation. If you see here, stricture, dilatation, stricture, dilatation. So this beading appearance is quite classical for primary sclerosing cholangitis. Look at this one,
Yeah.
where you can see that there is outline is irregular, some pseudo-sacules is there, and more beading and things like this is absolutely pathognomic, classical. So intrahepatic ducts as well as extrahepatic ducts are dilated. Now, this is two different cases where, again, similar findings are seen. And intrahepatic ducts, when there is acute phase. Now, let me take over. Candidate 9, thank you. Because of time factor, I will take over. I'm just going through. Actually, you be with me. I'll show you one last case. So just keep unmuted. So if you see here, what happens is that when there is active inflammation, there will be enhancement, just like extrahepatic duct, intrahepatic duct dilatation can, enhancement can be there. So what's happening here? Overall, liver and spleen. Candidate 9.
So liver is hyperdense as compared to the
No,
spleen.
look at the shape. I'm asking you very.
Yeah. It is quite irregular. It's a cirrhotic liver and spleen is enlarged.
Excellent. So the point is that primary sclerosing cholangitis in 10 to 15 years, more than 60, 70, 80% cases, they end up having cirrhosis. And so these terms should be in your vocabulary. Primary sclerosing cholangitis is immune-mediated disease. This is from your literature. No need of noting it down. Just take a picture. Immune-mediated disease causing progressive inflammation, fibrosis, and stricturing of intrahepatic and extrahepatic ducts, right? Intra and extrahepatic ducts. IgG4 cholangitis or autoimmune cholangitis is two terms should be in your vocabulary. First of all, IgG4 related sclerosing disease. Very, very important for the exam. Basically, what is happening? It is a spectrum of disorders characterized by tumor-like lymphoplasmocytic infiltration of varying degree with fibrosis in different organs. So what's happening is that plasma cells they get deposited in various parts of the body. Which parts? We will cover them shortly. And it will cause a pseudo mass like of an appearance. Later on, there can be fibrosis also. So and one of the stigmata of this disease is sclerosing cholangitis. When you see sclerosing cholangitis, usually it is associated with autoimmune pancreatitis. So you should know the radiology of autoimmune pancreatitis also. Now, these are the take-home points, and from here you can make your viva points and various long cases, etc. Primary sclerosing cholangitis versus autoimmune cholangitis, IgG4 related disease. In PSC, average age of onset is 30 to 40. So this is younger age. In IgG4, it is middle age. In CDS clinical onset, it might take months and years to develop. IgG4 related is more acute. Clinical course, majority becomes cirrhotic in 10 to 15 years. It is associated in 2/3 of cases with IBD. So it can be with UC, it can be with Crohn's disease, 70% with UC. So what is the take home here? Take home is that the examiner can show you a long case or a unifying diagnosis type of a case. I'll show you a few examples. When there is cirrhosis of the liver, there is a peculiar type of configuration of the cirrhosis in which we call it pseudo-tumor sign, caudate pseudo-tumor sign. The caudate lobe will be very hypertrophy. And there is a risk of secondary cholangiocarcinomas, 10 to 15%. But in IgG4 related disease, there is no risk of secondary cholangiocarcinoma. Look at these examples from literature. Caudate lobe hypertrophy too much, and this is a pseudotumor sign. Then this kind of a case can come with, as I told you that in UC or Crohn's disease, there can be fat deposition, submucosal fat deposition, or proctitis here. So you can give a unifying diagnosis. And then this is an MR, which shows enhancement of intrahepatic biliary system. This one is a secondary cholangiocarcinoma. Once you know this, you can make all of this together. And this is very, very important. Now, on the other hand, in autoimmune cholangitis, what is happening? That fifth to sixth decade, sudden onset, and association with autoimmune pancreatitis is very common. And this is a Viva question, by the way. This has been asked in the Viva. So you have to understand, even in head and neck, they will ask you the same question. What is the diagnosis? Diagnosis is based on combination of imaging, histopath, if you can get a biopsy, serology, where IgG4 markers will be increased, and also clinical response. For example, in orbital pseudotumor, you just give steroids or azathioprine at times, and clinically the patient will become better. It's a therapeutic trial also. Clinical course is variable, but it can improve spontaneously also. 50% can relapse. Malignancy, no known risk of malignancy. So if you see this case, this is a classical exam case where you will see enhancement of the CBD and then the features of autoimmune pancreatitis. And this is the stricture. But the stricture is not pathognomic because this stricture can also be seen in other conditions. With autoimmune pancreatitis, it becomes pathognomic. So other things which, this is an extremely important concept. This is straight from StatDX. What I have done is I have just cut and pasted here. Simple as that. So you can read it from StatDX or any other resource. And the point is that out of this, there will be many, many Viva scenarios, many, many long cases. If you remember this, IgG4 related disease, or what are the most common organs which are involved? First of all, autoimmune pancreatitis, then sclerosing cholangitis, then sialadenitis, which is salivary glands, nephritis, lymphadenopathy. Less common, cholecystitis, orbital pseudotumor, classical exam case. We will come back to this when we do head and neck. Dacroadenitis, this is not for you for the exam. Retroperitoneal fibrosis, it has come in the exam so often. Thyroiditis and pneumonitis, sclerosing mesenteritis. You know that hazy mesentery, misty mesentery. So all of these things can happen. So you have to remember this. And the book tells you that 60 to 90% have multiple organs involved. So if you know this concept, you can make your long cases out of it. Look at this case. This is enhancement, and with that, signs of autoimmune pancreatitis. On a biopsy, what you can find is that you can find plasma cells, immunohistochemical staining is there, and you can see IgG4, evidence here. So this is how you diagnose it, and there can be Viva questions. And one final point is autoimmune pancreatitis. I realize that this is 9:10 in the night, but this is the final learning point, and then I'll show you a case and we'll finish. So if you can concentrate on autoimmune pancreatitis, what are the radiological findings of autoimmune pancreatitis? The pancreas will be bulky. It will be classical, this sausage shape or comma shape. It is, and then there will be a pseudocapsule. This pseudocapsule will be low density on a CT, high intensity on an MR, and it can enhance. This pseudo capsule actually is a what we call fibrosis, and so it is not fluid; it is fibrosis, pseudo capsule. And then at times enhancement will be less than rest of the parenchyma, like this. So these are the classical signs of acute pancreatitis. And with that, if you see dilatation of CVD, then this is autoimmune pancreatitis and autoimmune cholangitis together. So last case of the day, candidate 9. This case presented with inguinal and axillary lymphadenopathy, night sweats, loss of appetite. On a CT scan, we picked up axillary lymphadenopathy, mediastinal lymphadenopathy, hilar lymphadenopathy, mediastinal here also, and retroperitoneal lymphadenopathy, inguinal lymphadenopathy here. What do you think is happening to the pancreas?
Pancreas is swollen, is sausage shaped, and there is a bit of pancreatic duct dilatation as well. And so I'm thinking that, but I cannot see any, yes, and there is no halo around the pancreas. I'm thinking IgG4 disease.
Yeah, of course, it becomes very difficult in the real world. We reported it as possible lymphoma actually. And you can understand that nobody looked at the pancreas very carefully. And we just reported it as, lymphoma as the first. And we did a PET scan. And this is the PET scan. What do you think is happening in the pancreas? Over to you.
So the pancreas is very hot on the PET scan, showing FTD activity. So this means that there is some inflammatory process going within the pancreas, and the lymph nodes are also showing increased uptake with FTG.
And what is it?
So these all, when we are tying up them together, this is IgG4 disease.
Right. So you see, it becomes a beautiful case, unifying diagnosis. Nothing else in the, there was nothing on the pancreas as far as a mass or something. Whole of the pancreas is enhancing. And everything else is enhancing. But if you look carefully, this is the location of the distal CVD, and that is also showing uptake. And on CT scan, this is the PET component of the CT, which is non-enhanced. So this is it, and look at this uptake. And on retrospective analysis, which I cannot show it to you very well on this, one can argue that there was subtle enhancement of the distal CVD correlating with this. So it's a beautiful case. So this case can come in the exam, the Hawaii is whole of the pancreas on fire. So this is autoimmune cholangitis or autoimmune pancreatitis. Okay, thank you very much, candidate 9.
Thank you.
And thank you very much, all of you. I urge you to, the feedback is on your, in front of you. So I urge you to give maximum feedbacks, as I urge you always, which is very important for us to collect feedbacks as evidence of teaching. Without feedbacks, there is no teaching. This is our concept. And you can also suggest something if you want in your feedbacks.